So we've just released a report a few days ago on the case for de-identifying personal health information. This report was in the works actually for quite a few years. It essentially summarizes the evidence that we have thus far on why de-identification is a good idea and when it is a good idea. You should have received an email with information about how to download the report. So what I will basically do is go through the sections of that report and discuss the details around each section, and then give everybody the opportunity at the very end to ask questions. And if you haven't received the report, it'll be posted online at the end of the presentation, or a link to it anyway will be posted online with the slides as well as the slides from this presentation. So I'll start off with section 1 of the report. If you have it in front of you, you can follow along. I'll start off with some basic, motherhood statements about the benefits of data sharing. And a good example of the benefits of data sharing comes from the research world. Um, so for research data, making them available, the obvious benefit is being able to confirm published results, increase transparency. If raw data is available, then it's accessible for doing meta-analyses that combine data sets from multiple studies. Data custodians who make their data sets available get feedback that can improve data quality. There, for the whole system, or for society, so to speak, there are cost savings from not having to collect the data multiple times. Um, you minimize the need for the individual participants to provide the data repeatedly to different individuals, and the data is available for instruction and education. And just to emphasize this point, at the end of last year, the Canadian Institutes for Health Research, the CHR in Canada, published a policy to requiring that clinical trials that they fund make their data publicly available at the end of the study. So this is really a push for transparency. At the same time, there's increased demand for health data. Of course, more data is needed for research purposes. I've attended presentations where the stakes were presented essentially as a matter of life and death. Of course, public health needs more data to detect and manage disease outbreaks. So all of these are good things, and we want them to happen. With better data, we can find efficiencies in the healthcare system. The more data we're able to gather and analyze, the more opportunities that will be detected to improve the system and find efficiencies. And of course, advertising and marketing efforts can be more targeted if the consumer or patient information is readily available, so that they would get the ads that would be more relevant to them. So these are all good things, and we want to make them happen. So the argument basically in this report and this presentation is that de-identification is really the main reasonable approach within the existing legal framework that would allow a lot of these things to happen. There are some exceptions, and I will cover those, but it is within the current legal framework, it facilitates all of this data sharing and addresses a lot of problems. There are essentially 7 issues that we will discuss as the motivations for this case. There are better risk management for internal uses, the fact that custodians are generally reluctant to share data, problems with the current consent models, costs for breach notification, unexpected uses and disclosures, the privacy protected behaviors by the public, and the erosion of trust, and the asymmetry principle around trust, and then a discussion of alternative access methods that can be used, and just a discussion of pros and cons around those alternative access methods. So really there's seven main points. Underlying all of these things are the limiting principles, which is how they're called in Ontario legislation, but there's similar terms used in other jurisdictions. In the US, HIPAA privacy rule talks about the minimal necessary criterion. Essentially, you do not want to collect, use, or disclose personal health information if other information will serve the purpose, and you want to minimize the amount of information that you use or disclose, collect, use, or disclose to only that is what is necessary to achieve the purpose. And one way to meet these principles is through de-identification. So if de-identified data will serve the purpose, then you should use de-identified data. And this is really kind of an underlying principle across all the 7 scenarios that, or 7 issues that I will discuss. Okay, so now we'll go to section 2, which is a little bit of background just to define some terminology and some terms. So in a healthcare context, you have individuals, or essentially the patients, custodians who collect data from those individuals. So this is collection. A custodian may disclose data to another custodian, and then a custodian may disclose data to recipients who are, say, external organizations that are not related to the custodian, or it can use the data, or the data can be used by an agent of the custodian or by the custodian itself. So for example, if you're a custodian as a hospital, and if you're an employee of the hospital, then you're essentially an agent. If you're a subcontractor to the hospital and you're performing activities that are related to the business of the hospital, then you're also an agent. So that's called a use. And if you are an external researcher to the hospital and you're requesting or getting data from them, then that's a disclosure. The distinction is very important because in most jurisdictions, the use of health information is permitted without patient consent or authorization. Whereas disclosure, there are conditions, and I mean, in most cases, the basic premise is consent is required, and then there are exceptions to that. So this is an important distinction, and we really divided them into 4 groups. We have the mandatory disclosures, which are disclosures required by law. For example, in some jurisdictions, gunshot wounds have to be reported to law enforcement. The communicable diseases are generally, in most jurisdictions, there are a set of communicable diseases that have to be reported to public health, and by the physicians who have see patients with those diseases, or by the laboratories who may do tests. So we'll not talk about mandatory disclosures because it is required, and a lot of these mandatory disclosures require identifiable information to be disclosed about the patient for investigations or for doing contact tracing, for example. So we'll not discuss mandatory disclosures. I'll move on to the other 3. You have uses by an agent for some secondary purpose. You have permitted discretionary disclosures. So these are not mandatory, these are discretionary disclosures for secondary purposes. So public health and research purposes are considered permitted or discretionary disclosures, which means basically that the data custodian may or may not disclose personal health information. For research, there are usually additional requirements around research ethics boards. And then you have other disclosures that are not covered by the above, basically. So for example, disclosing data to a commercial entity would fall under this other category. So I'll discuss each one of those. So section 3 in the report talks about agents. So agents are internal to the organization, or subcontractors. Usually some kind of contract between the custodian and the agent. So the first thing to note about agents is that in general, a large percentage, or say a non-significant percentage of data breaches are by insiders. I'll just show you some, I will try to show you some graphs if I can get this to pop up. There you go. So here is a distribution of data breaches based on one public database, is the data loss DB, and this is only for medical organizations. So this is organizations that are considered health information custodians, and we can see that, and this is between January 07 to December 09. Just to give you a sense, there were about 11.5% of breaches were insiders, malicious breaches, and about 14 just above 14% were insider accidental. So roughly about a quarter of all breaches were by insiders. And then if we look at the number of records that were involved in these breaches, um, again, the insiders, we have malicious, about 1.5% of all records, and accidental about 18 and a bit. So roughly 20% of all records involved in breaches from medical organizations during that period were due to insiders. So the key point here is that insiders represent a non-trivial percentage of the number of breaches that occur. Um, the malicious ones are for financial gain, revenge. Some people, when they leave an organization, take data with them to help them in their next endeavor, next employer, and so on. And then, of course, you have accidental, which is loss of equipment or inadvertent disclosure. For example, sending an email to a large number of people by accident. So this is important to consider because if insiders are a potential source of breaches, then it would be prudent to make sure that they only have access to the data that they need and at the level of granularity and detail that they need. If they don't need identifiable information, then they shouldn't have identifiable information. The same argument applies to subcontractors as well, in the sense that if they do not need access to identifiable information, they should not get it. Again, if you apply the limiting principles and as a risk mitigation strategy, that would be a prudent thing to do. Now, in section 4, we will talk about the permitted disclosures. And this is also very important. We've done a number of studies around this issue. Some of them haven't, some of them have come out, some of them are still in the process of coming out. But in general, many data custodians do not want to disclose patient information unless it is de-identified, even if they are permitted to do so. Let me go back to the mandatory disclosures issue and public health. I mean, even though communicable diseases, reporting of communicable diseases is mandated, there's a huge amount of literature making clear that providers underreport mandatory diseases. So they don't report it. Even though it's mandated and it's required by law, the underreporting is significant. It varies by disease, of course, but it's still quite significant. And this is across the world. I mean, studies have been done in multiple countries. So when it's discretionary, it should be no surprise that there's the reporting or the willingness to disclose personal health information is going to be very low. And for the mandatory reporting, one of the reasons that have been cited for the unwillingness to report is privacy and impact on patient-physician relationship. So the fact that it's permitted doesn't mean that it will happen, and in general there has been resistance for the disclosure of this kind of information. And part of it also is that providers are concerned about their own privacy. So in a recent study that we did regarding the reporting of influenza-like illness by family doctors, one of the concerns was how the information will be used in a way that would affect them. So it's not just patient privacy, it's also secondary uses or applications of the information that may affect the providers themselves. And we see that whether the provider is a physician, individual, practitioner, or it's an institution. We see that with institutions who are reluctant to report, for example, infection rates because of the repercussions. You know, in hospital infection rates, various types. So the flip side of this, of course, is that most are willing to disclose patient data if it is de-identified. So rather than go into battle, so to speak, and try to convince the custodians to disclose PHI because they're permitted and because there's a public good, it's just much simpler to de-identify the data, and then the project progresses much smoother. And this has certainly been our experience. Okay, now the next section we'll talk about consent, and in the report there's a very large section which is essentially two systematic reviews of the literature on the impact of consent. The evidence is so overwhelming that you cannot argue this point. So I'll just kind of summarize the facts. In the context of clinical trials, and most of the studies on consent were done in the context of research. So one systematic review was actually a systematic review of systematic reviews. there's overwhelming evidence that the consenters and non-consenters differ, right? So in general, for study, the default is usually to try to obtain consent. Sometimes it's not possible or practical to obtain consent for various reasons. So, for example, making contact with a patient to obtain consent may reveal the patient's condition to others against their wishes. So this would be an example if you call them at home or send them a letter, and then the parent or the spouse opens the letter and discovers something new, with the intention of seeking their consent. So you may not want to do that if there's a risk of this occurring. Maybe the size of the population is too large to obtain consent. For example, if you're an emergency department and you want to collect data from patients who come in, it's just not practical to go and obtain consent from every patient. Their numbers are too large and there are insufficient resources to obtain individual consent on a case-by-case basis. Patients may relocate or die, so it's not possible to obtain consent. There may be a lack of existing or continuing relationship with the patient, so it's difficult to approach them or have a context within which to approach them. There are risks of inflicting psychological harm if you approach patients and seek consent. You remind them of an incident, things like death of a child, for example. And then sometimes it's difficult to contact individuals through advertisements and other public notices if you don't know where they live, if you didn't collect information about the language they speak. So generally you start off by trying to get individual consent. For all of these reasons, you may not be able to obtain individual consent. However, even if you are able to obtain individual consent in the sense that none of these reasons apply, there is evidence, as I mentioned, of differences between consenters and non-consenters. In the clinical trials context, we found that very strong evidence, and in the context of observational studies. And they differ on important demographic and socioeconomic characteristics like age, sex, race, marital status, educational level, socioeconomic status, health status, mortality, lifestyle factors, functioning, where they live, urban versus rural. So in a lot of studies, demographics and socioeconomic status are important determinants of the outcome. So if your data set is going to be biased because of that, because of the consent process, then that may have an impact on your results as well. So, and of course, the act of obtaining consent may reduce your recruitment rates significantly, and that has repercussions in terms of time and cost. So in general, even if it is possible to obtain consent because of the bias effect, mainly, it may not be appropriate in some situations to seek consent. In those cases, the simplest thing to do is to de-identify the data. Either de-identify it at the earliest opportunity after collection, or de-identify it before it's used or disclosed for that purpose. And that there's no legislative requirement to obtain consent if the data is de-identified. So, and that's an important factor to consider. And like I said, the evidence is quite overwhelming. So, consent results in bias. It's just, it's the way it is. Okay, so the next thing we will look at is the whole issue of breach notification. In the U.S., most states have breach notification laws. In Canada, some provinces do. There's discussion at the federal level to have a federal breach notification included in the revisions of PIPEDA, the federal privacy law. The main thing to keep in mind is the number of breaches and number of records that are involved in known data breaches is quite high. I'm not going to say that the number of breaches is increasing, because actually the evidence doesn't support that. The evidence shows that the number of notified breaches has been decreasing over time, and that can be interpreted in a number of different ways. So that's a topic for another discussion. But certainly the number of records is quite high. That are involved in breaches is quite high. And the key thing here is that if the breach involves de-identified data, then it doesn't require reporting, because it's not personal information or personal health information anymore. In the U.S., out of all the breach notification laws, only 5 states actually have a requirement to notify medical information breaches. Most of the states, it's name, address, social security number, and financial information. Only 5 of them explicitly mention medical information. However, most health information custodians or covered entities do have financial information as well as by their patients, so does not necessarily make them exempt from the breach notification laws. So the costs of breach notification, the evidence suggests there are really three main things to consider. One is the negative impact on share price. A number of studies have looked at companies with listed in the on the stock market and examined the impact on their share price. The evidence is mixed, but in general, one can conclude that there's a small reduction or drop in share price soon afterwards. In many cases, the share prices recover, but there is a temporary blip in terms of the stock value of the organization. There's evidence of reduced loyalty and trust from the clients, and intention to or actual discontinuation of the relationship with the custodian after the individuals are notified of a breach. In terms of the actual cost to the custodian, about 300 per individual, or just under 300 based on the recent data for health information. And this involves costs for notification itself, so sending out the letters, any compensation. So if there's financial information involved, then usually the custodian provides credit report monitoring services for a year as part of the notification or compensation for what happened. There will be costs for the actual investigation to find out what happened. There may be penalties by regulators, and regulators are now there are examples of them penalizing organizations for particularly egregious breaches. But even not so egregious ones, they're being penalized. Organizations are being penalized as well. So I think one would expect to see penalties increasing over time. And then, of course, the cost for litigation. Now, litigation, I mean, generally speaking, unless you can demonstrate harm, it's very difficult to get any awards from courts. However, litigation itself costs money. So if you're going to go and defend a class action suit again by your customers, of course there's also the reputation damage, but it does cost money just to go through the exercise, even if at the end of the day it's either settled or thrown out, or maybe not even certified, but still all of these things cost the organization attention and money. So these are the main breach notification costs, and as I mentioned, if the data is de-identified, the organization can avoid some of these costs. One of the other big questions that comes up is, so what if health or medical information is involved in a breach, and what are the possible harms? What could happen? Big deal. What can you do with this kind of information? Well, really, there are three answers to this. The medical records may contain financial information. So as I mentioned before, you may have billing information in the credit card information, or information that can be useful for financial fraud. For example, mother's maiden name, date of birth, the information that's needed to open an account in somebody's name. So medical records may contain that kind of information. Medical records may have a financial value by themselves, and are extortion attempts. So here are two screenshots from a report by RSA, which they went into the underground websites, and they witnessed attempts to buy and sell health information. So in this particular screenshot from essentially a data trading website, this individual was looking to buy healthcare or insurance data. I'm looking for someone that is selling possible database dumps for healthcare or insurance providers. Also, completed HCFA 1500 forms will work. Now, these forms can be used to file fraudulent insurance claims, and that's basically the purpose of the data, is you can use it to file fraudulent insurance claims. Here's another screenshot. This particular individual was trying to sell 6,561 records or individual claims, and the data set includes the social security number as well as the diagnosis of the individuals, which includes HIV with specific infections, malignant neoplasm of lateral wall of urinary bladder, and so on. So as you can see, very sensitive information, and again, this kind of information can be useful for insurance fraud purposes if an individual gets access to that kind of data. But that data is worth money. basically. I mean, it is possible to buy and sell medical records and get compensated for that. Now, the third part of this are the extortion attempts. So, um, why would anybody want medical records? Well, for extortion. Two public examples. One was Express Scripts, which got a notice one day that individual had hacked into their databases and obtained data on their clients. Now, Express Scripts does health insurance claims processing. About 50 million individuals in the U.S. every year have their data passing through Express Scripts. Um, and the extortionist wanted money, of course, and sent them the data for 75 individuals. Later, it turned out that they had data for about 750,000 individuals in total. Express Scripts refused to pay, so the extortionists started sending letters to the individuals affected, telling them, I have your data, and some of them filed a class action against Express Scripts. The other example, of course, is the Virginia Prescription Monitoring Program. An individual defaced the website for that program, which allows providers to access a database of prescriptions. I mean, as you can imagine, sensitivity of that information, where prescription records on individuals for in the state was hacked into, and the extortionist in this case wanted. So the bottom is the actual extortion message or note that was left on the main page of the monitoring program on their web page. So you go to their website, you actually see the ransom note, and this individual wanted $10 million for not releasing the data on these 8 million odd patients. So again, data can have value. I don't know if these extortion attempts were successful, but there's certainly attempts at that. Okay, so basically the main point from that was data has value, a lot of value, and breaches can have, if data is lost or stolen, there's an incentive for certainly for individuals to get access to that data, and custodians can pay a heavy price if they have to go through the breach notification process. So the next thing is related to unexpected or unplanned disclosures of information. And I mean, I'll start off with compelled disclosures. Governments, of course, are the main culprit there, because in many cases individuals are compelled to disclose personal information to government, and they have no choice because the government has a monopoly in certain services. And of course, there's a threat of prosecution. A good example of that, which was in the media in Canada recently, relates to the long-form census, where as far back as 1986, the assistant chief statistician for StatsCan was noting that about 45 or 46 individuals were they were planning to prosecute them for not filling the long-form census, and more recently, one person was actually prosecuted, and the judge ruled against her. So there is in some cases even the threat of prosecution. So governments are in a particular in a category on their own in terms of compelled disclosure. You can argue when disclosure is not compelled, individuals have a choice whether to disclose their information or not. In some cases, that's not really a choice, but let's play along. The issue there is if these organizations that collect data are using it in ways that the individuals had never anticipated, then you run back into this trust issue and the loss of trust. So if individuals give data to government agencies and the government agencies do unexpected things, even if it's legal, I mean, not questioning the legitimacy of these uses or for the disclosures of the data. We're not even going there. It's just the trust issue that if people are surprised by how their information is used, then you start eroding that trust. So I'll give you one interesting example. This is information that was declassified in the UK, and it pertains to a cabinet document in the early 70s that was discussing, if you look at the bottom here, the transfer of the Catholic population from Northern Ireland into the Republic of Ireland. If you read the whole document, they're talking about a few 100,000 Catholics as a way to solve the Northern Ireland problem. So at the bottom they talk about transferring to the Republic of Ireland certain areas which contain a Catholic majority, or in moving individual Catholics from their homes in Northern Ireland to new homes in the Republic of Ireland. And then here's the map which used census data. So in this particular case, one can see that the census data was used to carve out specific parts of Northern Ireland which contained Catholic majorities, and actually part of it was also which parts had Protestant majorities, because they wanted to move the Protestants into the vacated areas, or the areas that were vacated by the Catholics. So this is quite an innovative use of census data. There are many examples of census data being used in innovative ways. I'm not going to go through all of them. Some of them are well known going back to the Second World War, but since then there have been a few other examples. The main point being that, again, nobody's questioning the legitimacy of this. It's when the public sees how that information that's been collected from them is used, they will, I suspect, be reluctant to provide information in the future, and again, you start eroding that trust in the organizations that collect data from them. There are also examples of commercial actors doing, again, unexpected things with data. So now there are a number of examples of health systems who are monetizing their patient data, which means essentially packaging it, documenting it, cleaning it, and selling it. And again, this may be for not questioning the legitimacy of it, and maybe for a very good purpose. It's supporting, let's say, for example, research or better public health. But the question becomes, what would the patients think if they are? How do you assure the patients that this has been done properly? What would the patients think if their health information is suddenly being monetized in this way? Something they may not have anticipated up front. And of course, now you see a number of competitions where organizations are making some of their patient data available for competitions. So, and again, there's evidence that competitions spur innovation. So the basic idea, you make a data set available and you give X number of dollars or a certain amount of prestige or an award to the first team that achieves certain objectives. In our context, these would be analytical objectives. So one competition I'm involved in terms of helping the organization release the data, they're promising a large sum of money for the first team that is able to predict hospitalization from a large data set. So they collect a data set, they make it publicly available, teams from around the world compete, and whoever hits the mark gets the money, but then it spurs innovation and results in new and interesting things being done with the data. Again, this would be a case where the patients themselves may be surprised that their data set is being posted publicly and used for these competitions. So the main point here is that if the data is properly de-identified, then you address a lot of these concerns. The public will not, and I'll talk a little bit about this later on, but the public will not, or the patients will not necessarily be, will not object to their data being used in all these different ways if it's de-identified at the earliest opportunity. It allows the data custodians to retain the value or extract the value from the data, either for government purposes, for commercial purposes, or for spurring innovation purposes. But you provide assurances to the individuals that at least their identity will be protected. Now, the whole issue of public trust and public behavior. In general, the public is more willing for their health information to be used and disclosed for secondary purposes if the data itself is de-identified. We have evidence that the public adopts, patients adopt privacy protective behaviors in order when they have concerns about how their information is being used. So 15 to 17% of US adults admit to doing that, and 11 to 13% of Canadian adults admit to doing that. And privacy protective behaviors involve things like not seeking care, lying to your doctor, not providing all the details in your medical history, seeing multiple providers, although with an interoperable EMR or EHR this may not work, but seeing multiple providers so that none of them knows the full story, self-medication, self-treatment. The most vulnerable populations exhibit these kinds of behaviors: adolescents, people with HIV or at high risk of HIV, for HIV, those undergoing genetic testing, mental health patients, and battered women. So the most vulnerable individuals tend to adopt these, more likely to adopt these behaviors. You also have to remember that lying to my doctor is really a socially undesirable thing to say. So when 15 to 17% of the public admit to such a socially undesirable thing, one can argue that the numbers are actually higher than that. So these are examples of these privacy protective behaviors. Oh, paying out of pocket is another one. If you don't want your insurer to know, have that data. And physicians also admit to they've been asked not to include certain information in their record, and that they have themselves withheld information due to privacy concerns. Just as an aside, I mean, one also has to remember that in most cases when insurance companies ask for medical records from physicians, most offices just send the whole file. They don't actually go through it and select the parts that are relevant to the query. It's just easier to send the whole file. So, whenever there's an individual consents to access to medical records in order to obtain insurance, they're essentially releasing everything, right? Here's an example of self-medication. So this is an article that appeared in the New York Times about Dominican women living in New York. The story is basically about using a misoprostol, which is a drug for reducing gastric ulcers, to induce abortions. The women, who of course did not want anybody to know that they were having an abortion, would go to certain pharmacists who will provide it under the table, and then they would take it and induce an abortion. And then of course, as you can imagine, there are horrible complications, potential complications from doing this, in an alley or in a bathroom. But this is true, and people do things like that because they do not want their medical record to contain sensitive information about them. The other thing to keep in mind is the asymmetry principle, which basically says that trust is hard to gain but easy to lose. Some of the reasons for this is negative events or negative news events carry more weight than positive ones. It's just called the negativity bias. It's believed that negative events are more diagnostic. People weigh negative information more greatly in an effort to avoid loss. Sources of negative information appear more credible and less self-serving. Therefore, it's easier to lose trust than it is to gain it. Of course, prior beliefs are important, so people tend to interpret information according to them. If they have negative prior beliefs, then negative events will just reinforce that. Undecided individuals tend to be more affected by negative information. And even people with positive prior beliefs, if they about an organization, if that organization does something that is they find unacceptable, they feel betrayed, and it has a big impact on the loss of trust in that organization. So these studies were done in the past in the context of nuclear power and genetically modified foods, but the trends are similar across domains in the sense that individuals, if they trust an organization, let's say the healthcare provider, this trust is very difficult. It took a lot to get it through many years and a lot of history, but it'll be quite easy to lose it, and harder to regain if there are too many negative incidents occurring. So it's important to keep that in mind, because as health information is disclosed and used for secondary purposes, if the public is not fully on board with that, then they may adopt these privacy protective behaviors, but also you're going to start seeing this erosion of trust. In the final section, I'll talk about alternative access methods. Two common methods that are used to access information. One is remote access and the other one is on-site access. With remote access, users access data, identifiable raw data, through read-only mechanisms. So tools like Citrix are often used for that purpose. And a slight twist on that is the remote location are designated. So you can only access from certain remote locations, not from any remote location. So basically, you access the data electronically. And then you have on-site access, where individuals come on-site and access the data there. And research data centers from Statistics Canada are a good example of that. The issues there are, first of all, the users must be fully trusted because they have access to raw data that's highly identifiable. You cannot protect against spontaneous re-identification. So if if an individual sees a patient that they recognize, their neighbor, their sister, you cannot stop that, because the data will be detailed enough that they can immediately, spontaneously identify those individuals. And of course, there's the issue of background checks that would be done on those individuals with remote access or on-site access, which may be costly and time-consuming. Another disadvantage with remote access is that it's really very vulnerable to phishing attacks or social engineering attacks. So a simple example of that is this individual who has remote access gets an email from the CIO of the organization saying, with a proper signature, and it's been, spoofed so that it looks like it's coming from the right place. So the CIO or CEO or scientific director says, we've been compromised. Someone broke into our systems, and please change your password immediately to protect this gold mine of data that we have. And click here on this link in order to go and change your password right away. Now, what do? Right, you get this email from the organization that's providing you with the data. It looks legitimate, and the link, you look at the link and it looks legitimate. You click on it, it takes you to a website that looks like it's the website of that organization. You want to be a good corporate citizen, you enter your previous password immediately and then enter a new password. Right? You've done your job, and you're really being a good corporate citizen and fulfilling your obligations to the custodian. Unfortunately, you just gave your password to somebody else who can then use those credentials, pretend to be you, and log in as you and access all that data. So basically, once you have a system that requires some kind of use of some kind of credentials, which most of these remote access systems are, you're running that risk. And these social engineering attacks are really quite simple to do. They're not difficult attacks to construct. With on-site access, the only main problem there is, of course, you limit access to a certain number of people because the users have to be physically present in the secure facility to access the data. So again, I'll go back to the identification. If you disclose data that's de-identified, you don't have to worry about these issues because the data is the probability of identification is low, so you wouldn't have to be concerned with the same issues as those two other alternatives. I'm not saying these other alternatives are not good. I'm just saying they have important disadvantages and they have to be weighed against other modes of accessing data. So in terms of concluding, my argument has been that we've identified 7 risks or 7 issues, and the identification is a good way to address those and manage those risks. There are good identification methods and processes and tools out there. So this is not some kind of magic or difficult process. There are good solutions out there, and they can solve some of these practical issues and risks that organizations may face. I put in here the link to the article as well. If you haven't seen it, or if you want to send the link to any of your colleagues, please feel free to do so, which details this case in far more precision and with references to substantiate all the arguments. Finally, here's the link to our website. So if you go there, you will find a lot more information about the work we're doing, plus other identification methods that can be applied to solve this particular problem. And thank you very much. Now I think we will take some questions. So I think you should see a question Q&A pad, and if you have any questions, please enter them there, and I will answer any questions that come in. Okay, so first question is, can you speak to any de-identification solutions? Well, for health information, I mean, this is something that we've spent a lot of time on, and there's more information on our website. You can see on the screen a link to the website and to the knowledge base as well, which has a lot of examples and uh, links to further reports. We've also built a number of tools that support the identification itself, and again, you can get more information about those tools from our website. Um, we are working on a de-identification manual, so to speak, right now, and it should be out in the next 2 months. So if you're interested in getting a copy of this, just make sure you're on our mailing list, which you can subscribe to again from our main website, and then you'll receive a copy of that as soon as it's available. Uh, but I mean, I would kind of as a general point, I would say that the identification solutions that exist today have we have applied them. They work very well, and they provide a good way for data custodians to manage the risk, the real risks, not the theoretical risk, but real risks that we know have happened. We've looked a lot at re-identification attacks, so we know what's doable. Re-identification attacks are actually very hard to do successfully. So, but I would refer you to our website for more information on that. Second question is, do you have any estimate on the percentage of providers choosing remote access versus on-site access or both? Um, a number of large data custodians, and here I'm only talking about Canada. I'm not. I don't have numbers on the U.S. or other locations, but they have started to look at that option. Um, some are providing remote access from specific locations. We did a review recently of large data custodians across the country, and the ones who are implementing this um, still don't have good mechanisms in place to allow individuals from different jurisdictions to access the data. So I think the primary objective primary objective is or seems to be to provide better access for individuals within the same jurisdiction, but from a different jurisdiction is still there's still complications. We have that report. It was done for Canada Health Infoway, and again, if you go to our website, you go to our technical report section, you'll see a copy of you'll be able to get a copy of that. But in terms of exact numbers, it's really hard to tell. But in general, I think it's mainly the large data custodians who can afford the infrastructure costs to implement these things, to either implement a secure location where individuals can come and do all the background checks and provide on-site supervision the whole time, or the technical infrastructure to provide remote access. So I would say it's not very common, but there are some organizations doing it. The next question is, if you are able to anonymize all personal data for each record, would that be a solution? I mean, that's basically what one would do. Yes, for with the identification is you would anonymize or apply the identification methods to each record. I think the trick is defining what personal data is. Names and addresses, social security numbers and so on are obviously personal information, but also they're indirectly identifying pieces of information like dates of birth, postal codes, race, ethnicity, socioeconomic status type variables. These can also be used for re-identification attacks. So if personal data includes all of those, then yes, this is exactly what one would do during de-identification. Alright, then the next question is, do I understand that data custodians can disclose de-identified data or only for primary purposes, not secondary purposes? Well, if a data custodian is collecting data for a primary purpose, I mean, I guess it depends what the primary purpose is. If it is for providing care, then they can disclose data to other providers within the circle of care without consent, or sorry, I mean, it's an implied consent. So for primary purposes, yes, if the primary purpose is providing care. In other cases, either the primary purpose, the individual consents to the primary purpose by providing their data, whether it's a compelled disclosure or not is a different matter, but the individual's consent, or it's an implied consent, provided through the laws of the land. In terms of their ability to disclose data for secondary purposes, Yes, they can disclose data for secondary purposes without consent. So in most jurisdictions, there are exceptions that allow for disclosures without consent. So I think both types of disclosures without consent are allowed. It really just depends on what type you're talking about and whether they fall under an exception or not. Okay, so as an organization, what processes do you need to go through to define an acceptable threshold where several health data domains are involved? Uh, I'm just trying to understand what health data domains mean. Um, I'm assuming that means data with different levels of sensitivity. So when you do the identification, you can assign weights basically to different types of information, and those those weights are taken into account during the identification process. So if certain types of data are more sensitive than others, then they will receive more de-identification than the ones that are less sensitive. So that can be managed within the context of de-identification. Um, okay, next question. Where a research project requires patient-reported outcomes for evidence of efficacy of a particular treatment regime, consent is necessary. How can you protect against the bias cohort in these situations? For example, when the hospitals don't regularly collect data related to confounding elements like socioeconomic status, it seems that identification without consent is not a viable option for most studies these days where emphasis is on evidence-based outcomes. Well, I mean, if you're looking at patient-reported outcomes, I guess there are a number of ways you can approach this. One is you de-identify the data at the earliest opportunity after collection. So, for example, if a patient-reported outcome is a scale which has, say, 10 items, then you would compute your score from the instrument from the 10 items, and then once you're done your analysis, you can de-identify the data, so it does not have to go back. You cannot link it back to the individuals. If you're doing follow-ups, there are ways where you can allow linking of longitudinal records without maintaining the identity of the individual. So I think even in those cases, you can de-identify the earliest opportunities, and there are ways for doing so. As an organization, it's just more prudent not to have these links back to identifying information if you don't need to. And I think even for patient-reported outcomes, it's not necessary to have that link established. If you need to do follow-ups, then you'd keep the patient's telephone numbers in a separate location and a unique number identifier, and you collect data and you put it in a database with a unique identifier, for example. So there are ways to address these issues. Okay, the next question. Can you make comments on data protection where personal identifiers are required for data linkage? So there are a number of ways to do secure data linkage, even secure probabilistic data linkage. Um, so I mean, take a scenario. You have two organizations that do not want to share data, but you want to create a linked data set from these two organizations. So there are protocols that have been developed and we've developed one ourselves, where you can link the data sets from these two organizations using a semi-trusted third party. So it doesn't have to be a trusted third party. A semi-trusted third party means you really don't trust them that much. And that semi-trusted third party can do the linkage for you without getting access to any identifiable information or using any shared secrets among the two data sources. So there are secure linking protocols now, and there are tools now that are becoming available for doing so. I mean, the secure linking protocols, maybe some that have been used in the UK, are not based really on technology. They're kind of based on procedures, where you have you maintain kind of trusted third parties to to do the linking for you. So that's an option, but I think the kind of most efficient ones would be secure linking protocols, where you use some tools or technologies to do this for you, and they guarantee that it's not possible to re-identify the individuals in those data sets. And then the next one, I think this will be the last question because we're running out of time. If only de-identified data is released, is there still not a risk of this data being linked with other data sets to re-identify? Well, de-identification is a probabilistic thing, so you assign a probability of re-identification. And when you release the data, if you ensure that the probability is low, then the probability will be low. So even if external data sets exist that can potentially be used for re-identification, if you've ensured the probability is low, then it'll be low, right? It's never a guarantee that it cannot happen, but you can make it sufficiently low, and then you put in place other mechanisms to protect the data. So if you're giving data to a researcher, you'd have data sharing agreements in place. If you're putting data in the public domain where you cannot have data sharing agreements, then you will push your probability as low as possible before you release the data. And as an important point is we've done re-identification attacks, and I know a lot of people talk about re-identification as if it's you go out and buy it from the supermarket. It's really hard to do. It's very, very difficult to do successful re-identification. The hit rate is quite low, and part of the reason is it's not that easy to get external databases to use for linking, and the quality of the data is also an issue. So you have data quality problems that if you try to use databases for re-identification that have poor quality, your hit rate is not going to be that high. But in general, it's something you can control by manipulating this probability of re-identification. If it's done well, then the risk can be low. It's something you set yourself. I know there have been claims that that re-identification can be done. These claims are not supported by evidence, and we've done a number of webinars around this issue where we've refuted those claims with the same evidence that those authors have used. So I think you have to be careful what you believe. Basically, re-identification is very hard to do. The other point was whether no breach notification is necessary if the identified data is breached. Well, I mean, if the data is de-identified and that probability is low, then a case can be made that this is no longer personal information, and therefore the requirement doesn't kick in. And in U.S. states, it's very specific about the fields that are concerned. So it's actually easier to determine whether breach notification falls within scope or not. In other situations where it's not specified precisely, again, if you can make the case that this is de-identified data and the risk is low, then and if you can substantiate that claim, then this would not fall under the scope of the many breach notification laws that are out there now. I think I will leave it at this because we're running out of time. Thank you so much for participating. I will make sure that within the next 24 hours or so you get the slides. We'll post them online, and you'll get an email with the location of the slides. Hopefully that's been informative. And if you have any additional questions, please feel free to send me an email. My email is here on the screen. I'll be happy to answer and provide you more information if you have any additional questions about the material in the presentation or any other issues that related to the identification that you may have questions about.